Okay, so in chapter 33, we're going to talk about alterations in female genital and reproductive function. So we're going to first start out talking about the menstrual disorders. And the first one we'll talk about is amenorrhea. A means lacking, menorrhea means menses. So amenorrhea is absence or suppressions of menstruation or no menses at all. Now, this can be caused by different hormonal disturbances, stress, or even neoplasms of the ovaries, the adrenal gland, or the pituitary gland. Now, the treatment for amenorrhea is really going to be aimed at the underlying cause, whether it's hormonal or stress or neoplastic. And if it's due to a neoplasm of like the ovary, the adrenal gland, or the pituitary, this might require surgery to remove that particular secreting tumor. Uterine prolapse is going to be one of these conditions where the normal uterine position is offset. So prolapse means sinking of the uterus from its normal position. And with uterine prolapse, the uterus starts to protrude down through the vaginal canal. And this comes from relaxation of pelvic structures and the cervix. You know, when we talk about pelvic structures, this is going to refer to things like your suspensory ligaments, like the broad ligament and ovarian ligament and round ligament that normally hold the uterus in position. If those are relaxed, then the whole uterus can start to sag or kind of sink into the vaginal canal. This can occur at any age, but it's caused by congenital defects. It can be due to pregnancy, even childbirth, because in pregnancy and childbirth, there could be damage to the suspensory ligaments or, at least sort of stretching and relaxation of those ligaments. And then with congenital defects, it could just be that the suspensory ligaments don't form normally and the uterus can start to sort of sag or protrude through the vaginal canal. So what this slide is showing then is the difference between the different degrees of prolapse. So first degree prolapse is where you get a slight sort of protrusion where the cervix is now closer to the vaginal orifice. And this is a more of a minor degree of prolapse. But there is sort of an infolding of a vaginal wall, which can make someone at risk for infection. Now, with second degree prolapse, what happens is the cervix is now visible through the vaginal orifice, and the uterus is actually pushing through the vaginal canal. And you can see that these lines, these infoldings, this was the vaginal canal. But if you pulled this uterus back, then the vagina would be there. So basically the uterus is now occupying the vaginal canal, and the cervix is present at the vaginal orifice or opening. Now, third degree prolapse is where the uterus starts to protrude out through the vaginal orifice, and now what happens is a lot of these structures are now going to look more externally. In fact, this is an example of third degree prolapse on this side. So you can see mons pubis, you can see the labia minora, the clitoris, and then all of this here is the wall of the vagina, and deep to that you'd have the uterus. This is actually the opening to the cervix. So here's the cervical os, like the external os. And so basically what this is where the vagina is sort of turned inside out due to a sinking uterus. This would be considered a third degree prolapse. Now, the uterus can also be in different positions, and one we'll talk about is the retro displacement of the uterus. This is where the body of the uterus is displaced from its normal position, and it's where it's either flexed or rotated into the posterior portion of the pelvic cavity. It can be detected in 20 to 30% of women based on the location of the cervix, but it may be present through a woman's life or develop after childbirth. So what this slide is showing in the different uterine positions, we can have anteverted, where the whole uterus is sort of tilted anteriorly towards the anterior part of the pelvis. There's mid position, where it's just sort of right in between the bladder and the rectum, just right in between. Now, retroverted is where the uterus is actually tilted towards the posterior abdominal wall. Retroflex is where it's bent. It's in mid position, but it's bent towards the posterior abdominal wall. And then anteflex is where it's in mid position, but it's flexed towards the anterior part of the abdominal wall. You might wonder, well, what's the significance of knowing which way the uterus is sort of directed? Well, during pregnancy, it's the fundus of the uterus, this top curvature, that expands outward as the fetus grows larger. So if someone has an anteverted uterus, that means it's going to expand out into the anterior surface of the abdominal wall. So they're going to carry that pregnancy more in the belly, so they say, or they're going to have a lot of the fetus actually kind of more up against the anterior part of the abdominal wall. Now, compare that to something like retroverted, where if the uterus is actually more tilted backwards, once the fundus expands, that means that the fetus is going to be it's going to be carried more in the lumbar area, and it's going to protrude on different abdominal organs. And so, knowing the position of the uterus, you can actually make some predictions about, someone's pregnancy. Now, we're going to move on to talk about inflammatory and infectious disorders of the vagina and uterus. And the first one we'll talk about is pelvic inflammatory disease, or PID. Pelvic inflammatory disease is really just inflammation of the internal pelvic organs in females, and it's most commonly caused by Neisseria gonorrhea or Chlamydia trachomatis. And what happens here is that due to this infection, you get alteration of cervical mucus that not only prevents bacterial agents from spreading into the uterus, but as those bacterial agents spread into the uterus, they can start to infect the inner uterine lining as well as the fallopian tube. Now, some of the risk factors for PID would be things like pelvic surgery, IUDs or intrauterine devices, abortion procedures, or infection after pregnancy. And so what this slide is showing then are the different routes of infection. We see that Staphylococcus and Gonococcus will travel up through the cervical os and through the uterus, and then start to go through the fallopian tube out, maybe even to the pelvic cavity. Now, Streptococcus can actually just spread right through the myometrium directly into the pelvic cavity, where it can affect things like, the ovary here. Now, these are just some different common sites of pelvic inflammatory disease, and depending on the site of infection, then we have different names for that. So, inflammation of the uterine tube we call salpingitis. Inflammation of the ovary is oophorytis. Otherwise, inflammation of the endometrium, endocervicitis, or endometritis. We can have parametriitis, which is sort of on the outside or around the uterus. But what's interesting too is these infections can also lead to the formation of pelvic abscesses, and these abscesses can actually start to grow and lead to more inflammation that can impinge on nearby structures like blood vessels and nerves. Now, some of the clinical manifestations of pelvic inflammatory disease, well, for one, you're definitely going to see abdominal tenderness due to that infection and pelvic pain. Now, you might see some cervical pain and tenderness on palpation. And due to the infection, you're going to see things like fever and elevated white blood cell count, as well as a purulent vaginal discharge. Purulent means pussy. So depending on the site of that infection, especially if it's at the cervix or the more proximal parts of the uterus, you might see a pussy discharge going down into the vagina. Now, pelvic inflammatory disease isn't only just painful, but it can also lead to things like infertility. Due to that inflammation, you can see that scar tissue may form, and that scar tissue may actually prevent proper, fertilization occurring, and therefore lead to things like infertility. It may also make someone at risk for ectopic pregnancies, where a fertilized embryo might implant somewhere else other than the endometrium of the uterus, and large abscesses can actually form and persist for long periods of time as well. Now, one of the neoplasms of the uterus, these are benign, we call uterine leiomyomas, or myomas or fibroids. And these are most common form of uterine growth. You find them in about half of all premenopausal women and 20% of women older than 35. It's more common in African Americans than whites, and this makes its appearance and grows during reproductive years. It turns out that the growth of these fibromas or fibroids or leiomyomas is actually due to high estrogen levels and high growth hormone levels. So if someone has really high hormone levels, particularly estrogen and growth hormone, this can put them at risk for a leiomyoma or a fibroid. Now, these fibroids will protrude out along the uterus, either externally or internally, or actually kind of occupy space within the uterine wall. And they're particularly painful due to this overgrowth of tissue. It kind of impinges on nearby nerves, and they can actually be more painful. Now, depending on the site of the growth, it can also lead to things like infertility and ectopic pregnancy by potentially hindering the normal movement of like a potentially fertilized egg, or they might block sperm from getting up towards the egg. So these things aren't totally riskless. Now, other benign growths include things like endometriosis. Now, what's interesting about endometriosis is actually the presence of endometrial tissue outside of the lining of the uterine cavity. We know that the endometrium is normally found inside of the uterine cavity, or sort of just deep within the uterine space. But with endometriosis, you could find endometrial tissue somewhere else. So you might find this actually going to be, it could be found along the ovary, the peritoneum, in the pelvic cavity and abdominal cavity. You might find it in the oviduct, around the outer layer of the uterus, around the bladder, around your intestines, or even around the lungs. We talked about how when you find endometrial tissue around the lungs, we said that was catamenial pneumothorax. So it's kind of interesting that this endometrial tissue can spread. But what's interesting about this too is that this endometrial tissue will grow and shed with normal uterine cycles. So during the menstrual phase, wherever this endometriosis has occurred, you're going to see shedding of this as well. Now, with cervical cancer, it's detected by looking for cervical cells. You do Pap test. Some of the causes of cervical cancer will be like HPV. There's certain specific types of HPV or human papillomavirus that cause cervical cancer. But some of the risk factors for cervical cancer include things like intercourse at a younger age, multiple sexual partners, and these increase your risk of being infected with strains of HPV that cause cervical cancers. Multiple pregnancies due to irritation of the cervix, herpes virus type 2, so genital herpes virus, especially HSV2, can put you at risk for cervical cancer, and even other sexually transmitted infections, because they can irritate that cervical mucosa, that can lead to metaplasia, dysplasia, and then cancerous growth. Now, endometrial cancer involves cancer of the endometrial lining, and the risks of this include things like infertility, late menopause, obesity, diabetes, and hypertension. But some of the clinical manifestations of endometrial cancer will be bleeding between menstrual periods, abnormal sort of spotting and bleeding, even between normal menses, or even post-menopausal bleeding. After someone's ovaries have stopped producing new eggs and stopped releasing estrogen, then you stop seeing those sort of growing and shedding of the endometrium as you would see with normal uterine cycles during reproductive years. But if someone has endometrial cancer, they may actually start to get some bleeding even after menopause, and it's due to the growth and shedding of this endometrial tissue that's now cancerous. Now, there are other pregnancy disorders that we'll discuss, like pregnancy-induced hypertension, called PIH, or toxemia or preeclampsia. It affects about half to 10% of pregnancies. It's the leading cause of pregnancy-related deaths, and it's characterized by a rapid rise in arterial blood pressure that's associated with loss of large amounts of protein in urine. Due to this severe hypertension, you get hypertensive emergency, which leads to the disruption of the glomerular membrane. Protein ends up in the urine, and then you start to get hypoalbuminemia and all the sequelae that result from hypoalbuminemia. Now, hyperemesis gravidarum is actually excessive vomiting during pregnancy. It occurs in about 1 in 1,000 pregnancies, so 0.1% of pregnancies. So it's not super common, but it's actually due to an abnormal response to large amounts of human chorionic gonadotropin. This is released by the placenta to prevent the mother from rejecting the fertilized egg. The zygote. But some of the clinical manifestations of this include things like severe vomiting, and due to severe vomiting, you might see electrolyte imbalances from loss of things like potassium and hydrogen ions. And from hypovolemia, or low blood volume, you might see some liver and kidney damage as well. And this, if it's severe enough, it can lead to death. So this comes from excessive vomiting due to abnormal response to HCG. Now, breast cancer is the most common form of cancer in women in the United States, 25 to 75 years of age. It's a leading cause of cancer death in the U.S. and affects women most commonly between 40 and 44 years of age. You do find breast cancer in males because males do have breast tissue, but it's about 100 times less common in males than females. Now, it's more common in white women in the U.S., and what's recommended to avoid to help identify and avoid breast cancer from spreading too quickly are frequent clinical breast exams and mammography after age 40. Now, these recommendations are updated pretty frequently, so you want to make sure to stay up to date on the current recommendations. And I think the last I heard is they're actually asking that women get not yearly clinical breast exams, but actually, every other year getting a mammogram. Now, some of the risk factors for cancer would be things like giving birth before 18 years of age actually decreases your risk. Giving birth after 35 years of age increases your risk for breast cancer. Also, having low parity, so not having that many children. Let's say if you just had one child, that actually increases your risk. Otherwise, high parity or having many children lowers your risk for breast cancer, as well as breastfeeding decreases the risk as well. In fact, some of the evidence for breastfeeding and breast cancer is in women who only breastfeed with one of their breasts instead of both, they're more likely to get cancer in the breast that they chose not to breastfeed with. And so all of these risk factors are based on sort of epidemiological data, but it actually does bring up some interesting points, especially because of the fact that women nowadays in the United States, they're not having children so frequently before 18 years of age. Because of careers, they're choosing to have children later in life, and we're having less children for a variety of reasons. One of which is like cost and career-wise, and things that would interfere with having 7 kids. So the low parity also increases risk, as well as the fact that mothers who have careers also may not necessarily have enough time to breastfeed. They might actually choose to put their infant on formula, and by not breastfeeding, this actually increases their risk. Whereas breastfeeding could actually decrease your risk for breast cancer. But remember, these are just risk factors. That doesn't mean that because you fit a particular criterion, doesn't mean you're necessarily going to get breast cancer. Now, there are some genetic factors as well. The fact it actually runs in families. So if you have a close relative like a mother or a sister that's ever had breast cancer, then your risk increases pretty dramatically. There are genetic risk factors that are specifically identifiable, like the BRCA1 and BRCA2 alleles. These are associated with breast and ovarian cancer. So you can actually get genetically tested to see what your genetic risk factor is for breast cancer. Now, in terms of the pathogenesis of breast cancer, the cancer cells are most often in adenocarcinoma, so they arise at the glandular ducts of the breast tissue. These lesions have infiltrating edges that begin to invade normal surrounding tissue, and the malignant cells can disseminate into lymph through the axillary lymph vessels. Now, the breast is particularly prone to metastases because it doesn't have a whole lot of structure to it. It's very loose tissue. So these metastases can spread fairly easily in breast tissue. And some common sites of breast cancer metastases would be things like your liver, lung, and bone, which are all highly vascularized. So it makes sense that the cells could deposit there. So what this slide is showing then is actually the spread of those malignant cells arising from the glandular epithelium of the breast, and they can spread along contiguous lymphatic pathways. And the way that breast cancer is staged and classified is based on the amount of lymph involvement. So like the number of nodes and where those nodes are located. We'll tell you about the degree of malignancy that it's occurred, and we'll tell you about whether it's like stage 1 or stage 4 breast cancer. Now, the 5-year survival rate for breast cancer is 98%, as long as there's no lymph involvement. Otherwise, if there's lymph involvement, that rate drops to 23% with distant metastases. And the more positive lymph nodes that have malignant cells, the less favorable the outcome is. So if someone has a lot of lymph nodes that are affected with these malignant cells, then they're more likely to pass more quickly. So a less favorable prognosis.